Hey everyone, it's Dr. Zubin Damania, aka ZDoggMD. All right, so welcome back to Incident Report. Today's guest is actually somebody I've been meaning to talk to, I've been hounding to talk to for like a long time. And it's Dr. Eric Strong. He is a hospitalist, internal medicine doc. We train in the same Stanford residency program. We're off by a few years. I think he was 06, I was 02. And the reason Eric piqued my interest, apart from being a fellow Stanford alum and a fellow hospitalist, is that he has one of the more popular free online medical education YouTube sites that I have seen. It's called Strong Medicine. I have it pulled up right here, and for people who are listening audio on the podcast, you can't see this, and that makes you a second-class citizen. So you can always click through to the link in the podcast description to see the actual video parts that you want to focus on. Otherwise, this is a great commute talk, because Eric and I are going to try to talk about how it is that we can teach using brand new media. How does that affect our careers, especially in academics and in healthcare? Should we be scared of this stuff? And what does it take to prepare a lecture? Because Eric's site, Strong Medicine, is insanely popular, insanely effective teaching tool. And it looks like he actually works on this stuff. Unlike me, I just freeball it. Eric Strong, welcome to the show, man.
Thanks, Zubin. Thanks for having me.
Thanks for coming.
Sorry it took so long to
Dude, I
make
know.
my way here.
Every time I'd come to the Bay, I'd be like, Eric, we got to get you on the show. He's like, yeah, cool. I'm on a sabbatical. Or, yeah, no, I'm in transition right now. And I'm like, you don't like me, okay? I can tell. We're co-created. It's like you get the people who kind of do the same sort of thing generally in the same room, and either they love each other or they hate each other. And I had no idea. And
it was just a schedule thing.
Okay, because I was taking it personally.
Yeah, well, I'm sorry.
Like, this man hates me. So how did we first meet at Stanford? You remember the story, and we haven't talked about it because this is the first time we're seeing each other in what, 15, 20 years? I forget now.
Yeah, not 20 years.
Yeah. I like to.
20 years ago was pre-California for me. So
where did you go to med school?
I went to NYU.
Oh, you're NYU, which now has free tuition. Do you feel like you were robbed?
Yes, absolutely.
And
I'm still paying that back. I'm going to be paying it back for another 20 years probably.
God, do you still have loans? Seriously?
Yeah.
And because NYU is a private school.
Yeah.
And did that affect your choice of career ultimately, or?
No, I don't think so.
Yeah. Because you weren't thinking, oh, I'll become a hospitalist because I'll be able to pay a hospitalist at the VA. Yeah. Because I'll be able to pay my loans back.
That didn't really cross my mind.
And so you did your Stanford training. How did we meet?
Intern year, there was an ACP conference, local chapter of the ACP was being held down at Monterey, and Kelly Skeff, our program director, was like really encouraging the interns to submit posters, and so we came up with like some weird clinical vignette poster. It was not very impressive, but we went down to the meeting, which is cool because it was like the first meeting as a physician. I was just graduating medical school. And the night before the conference, there was this dinner out that Stanford was, everyone's Stanford affiliated, all the residents were eating at this nice restaurant right on the water, like sort of like near the wharf in Monterey. And there was going to be a talk, quote unquote, by yourself. And when we get there, and the dinner was great, and then afterwards you stood up, and I sort of had heard of you and knew a little bit about you, but I don't think I'd ever like actually seen you speak before. The talk was actually a stand-up routine, and what was funny about it was because it felt like the intention was for us to have like this private room where you could just do your routine and it would just be totally free, and just like all your standard jokes and about medicine, about like all the gross, grimy parts about medicine, like colonoscopies and things like that. But I didn't have a private room for us. It was like the middle of the restaurant. That's one really long table that we're all like 20 of us at this one long table, and you start giving your stand-up routine in the middle of this really nice restaurant, and there's like couples like having like their 25th anniversary dinner and stuff, and you're like talking about like bowel preps, and it was just hysterical because like all of us were like just on the floor laughing, and all these just regular people just out for like a nice romantic dinner were just like, what's going on here?
Oh my God, dude!
And that was when I was introduced to Zubin Damania.
You know what, Eric?
I don't know if you remember that.
I hadn't thought about that. Probably since it happened, because it was so traumatic for me. Because now I'm remembering everything. So guys, the restaurant was called The Fresh Cream, which I believe I believe I remember because I opened the stand-up with, I'm glad to be at a restaurant that sounds like it should arrive in my mailbox in a brown paper wrapper. Like it's some kind of, magazine. And they told me that we'd have a private room, and Greg Engel set it up, I think. Yeah, Greg Engel, who's a cardiologist.
Guy.
Great guy, set it up, and he's like, it'll be great. You can do your stand-up routine, new residents, American College of Physicians, but our own private thing, Stanford thing, it'll be awesome. So I brought my A game, right? I brought Dr. Bobo, who I believe was a PA, a primate assistant. So the joke was that it really only takes a low-level primate like a bonobo or a chimp to do 90% of what we do. And it's mostly Haldol darts, just, a little aspirin. And I was doing this kind of thing. And you're right. There was a woman having like a 25th anniversary over there. Kelly Skeff, who's our program director, who is the butt of 90% of my jokes, is sitting in the front. Was I told? No. So half my thing is I'm doing Kelly Skeff's voice. I'm like, it's wonderful that you guys are the learners who are learning to learn from the learners who are teaching the learners how to teach. And I would do that, and there he is staring at me like this. And I'm already an attending, but there's still this like stress.
Oh, yeah,
this guy's
absolutely.
my program director. Yeah. And so thank you for reminding me of, I swore after I did that show, I was never going to do stand-up again. I was like, I'm done. And here I am, somebody.
Well, I'm very glad that you forgot that promise to yourself.
I'm glad you brought that back. See, you really are trying to hurt me, Eric. So that's funny. So that's how you first encountered me, and you were in the audience, and that was weird. But so now fast forward, you finished Stanford. How was residency for you, by the way?
It was fine. I mean, residency is tough. I mean, it's tough no matter where you go. I don't think Stanford was any better or worse than any place else.
Yeah. Here, come up on this mic. We want to hear you good. Yeah. Ugh. I know. It's like one of those things where like most people don't do this fancy mic, but it sounds so much better. You can sound like NPR voice. And so it was just about, that's how I felt about residency, actually.
Yeah. It was manageable.
Yeah, it was manageable. It wasn't the most traumatic thing. Medical school was more traumatic for me, actually.
Yeah, I would agree with that.
Yeah. What was the most traumatic part about medical school for you? Because
wow, so many things.
I know, right? Where to start?
I think probably the first thing was my first clerkship. If you finish second year of medical school, you take the boards, and then you start clerkships. My very first clerkship was on the forensic psychiatry unit at Bellevue.
Oh
right?
My God!
So basically, like patients that are, I mean, for lack of a better term, like criminally insane, like patients that had done horrific crimes, committed horrific crimes. While being mentally ill and having psychiatric illness that was sort of confounding some of their understanding of what they were doing. And it was, these are dangerous people, not because they knew what they're doing, just because they had demonstrated in their past that they had done and had the capability of doing really horrible things. And what was difficult about it was not just that the stress of that and having to you would go through like this lockdown, to go into the ward. There's literally like a police station there in the hospital. You'd go through the bars with a slide across. They'd have to pat you down and check for weapons and contraband and whatnot. But then there was no other residents on the service. It was just me as a medical student, no interns, no residents, and one attending. And the attending was clearly not interested in essentially teaching. Like he was not there to impart wisdom on me, not there to show me the ropes. And if it was one thing, I think. If it was my fourth or fifth rotation clerkship, I think I would have been wow, this is really interesting. It's so cool. It's so amazing. But if it's the very first time I'm being introduced to real patient care, and that's the patient population that I'm working with, and the person who's supervising me and responsible for not just teaching me, but responsible for my safety is super disengaged. It was a really horrible experience. And it was just unfortunate.
That's stunning because it also brings me back to my own psychiatric experience, Langley Porter at UCSF. And it was the opposite. It was this very nurturing inpatient. Now the inpatients were very ill, profoundly. If you saw an inpatient OCD, right, and we would see things like that. This person was so OCD that it was absolutely destroying not only their life but everyone around them. And so there was a gentleman I remember. Now he's probably long since deceased, so I don't think I'm even violating HIPAA by even vaguely talking about it. And this was from the 90s. But he would have these intrusive sexual thoughts, and then he would have to tell you about them. So he's like, well, I'm really right now thinking about masturbating, looking at you. And I'm like, this got real really fast.
Yeah.
And you're at 25 or whatever, right? Yeah, I mean, you're not, it's not a world experience that you've been prepared for in any way. Yeah, but they actually were quite good. I have to give them a shout out. There were much less good mentors in my training. OB, others were just really scarred me. But yeah, so I feel you. But so Stanford, was much better actually. I think.
Yeah, after that, everything's a piece of cake after that experience.
So after residency, did you go right into a job, or what ended up happening?
Yeah, I went right into a job. So my wife and I, something else that made residency, I think easier for me to handle them was that I couples matched with my wife.
Oh yeah, what does your wife do?
She's a cardiologist, she's an electrophysiologist.
Nice. EP.
And EP, yeah.
Yeah.
And she applied third year for a cardiology fellowship. She didn't know where she was going to end up in the country, so we couldn't just you can't apply for an academic job if you can't commit to long term. Like no one wants to hire, like no academic center wants to hire someone who may just be jetting in just a year. And so we both ended up attending for a year at a community hospital in the East Bay. And then when she matched at Stanford to do fellowship here. And then I was like, oh, that's awesome. And after our year is up, I was going to reapply, or not reapply, but apply for a position over here. And the VA had an opening, and so.
And so you were hospital medicine at the VA Palo Alto.
Mm-hmm. Yeah.
And so you work with Christoph Gimler and these guys. Yeah. Gimler was my chief.
Yeah.
Gimler, I can't tell these stories because it's not fair to Christoph. They're funny stories. These are classic, like insane stories from residency, but he is a good human being, a very, very disciplined guy.
Yeah.
So at the VA, when did you start realizing that you wanted to make videos on YouTube? Like, how did this happen? Because most doctors shy away from social media.
Yeah, it's nowadays if people create YouTube channels, like medical YouTubers today, I feel like it's done much more deliberately than it was back when I started. My first video was over 8 years ago, and it was very accidental. So
wait, you did your first video 8 years ago.
Yeah, 8 years.
So mine was 9 years ago.
Okay.
So we were basically contemporaries on YouTube.
Yeah.
That's crazy. So please continue.
Yeah, no. So at the time, I was not just at the time, but still. I give some lectures to the residents in the Stanford Internal Medicine residency program, noon conferences. And the ACGME has some requirements that because they can't guarantee every resident can get to every conference because it might be their day off, patient might be ill and they can't get there. Any lecture that's given, they have to make the PowerPoint slide deck available online for the residents to view afterwards.
That makes sense, yeah.
Which sort of makes sense.
But PowerPoints themselves are dumb.
Yeah, exactly. But then if you think about it, you're like, so this busy resident who's already working 80 plus hours a week, super stressed out, burned out, tired, etc. Are they really going to go home at 10 p.m. and decide, oh, you know what, I had that crashing patient this afternoon. I didn't get a chance to see Dr. Strong's lecture on hyperglycemic crises. While I'm chowing down my one meal of the day, let me open up this PowerPoint slide deck and kind of click through it and see what I missed. Like no one's going to do that, right?
Yeah.
And so what occurred, so thinking about this, when I was asked to provide my PowerPoint decks, I thought, this doesn't make any sense. Like no one's going to watch, no one's going to look at this PowerPoint. So let me just make the experience incrementally better by let me at least record a narration, stitch narration together with a PowerPoint and make it a video. And then Stanford can put this up on their site as a video, and that way it might make it that much more likely that someone, instead of like being 0% chance someone's going to look at it, maybe like 1% chance they're going to look at it.
That's a big incremental change.
Big incremental change. Yeah. And so then I asked the internal medicine program, I said, this is what I wanted to do. And they said, well, that's great, but we don't have any place to put it. And so what do you mean? Like, oh, well, just like our website, our menus and directories, they don't have a place that can really accommodate a file of this size and video format. We can't, like, it sounds great, but we can't do anything with it.
This sounds like 2011 or something.
Yeah, exactly.
Yeah, exactly.
So I said, well, I was like, what the heck? I mean, everyone's got a YouTube channel. Everyone knows what YouTube is. Even back then, people knew what YouTube was. Let me just put up on YouTube, right? And so I just made this thing. It was called like Eric's Noon Conferences or Eric's Medical Lectures. And I started putting up my noon conferences up on YouTube, and then just advertise to the residents in the program and said, hey, if you missed the conference, you can watch this video, which is incrementally closer to the experience. Still very far removed from what the experience would have been in real life, but incrementally closer. And so I got some, like one person watched like the first one, I think. Did
it literally have one view?
Yeah, I literally had one view. One view. And for the first month of my YouTube channel, I think I had like 2 subscribers that were both Stanford residents, which was like great. Like shout out to those guys.
Yeah.
Whose names unfortunately I've long since forgotten. But once it's on YouTube, like it's out there in the world, like it's public, and so anyone can find it. And so if you're, some random resident somewhere else, or if you're a patient, or if you're a high school student who's just really motivated to learn more about medicine, or if you're a student somewhere in the world that doesn't have as robust medical training as we have in the US, you can just go to YouTube, you type in like hyperglycemic crises, and suddenly like my video is popping up, and people started watching it. And then sort of the way the YouTube algorithm works is, the more views it gets, the higher the video comes in the search algorithm. And so sort of like views beget more views.
Yeah, Pareto distribution, you're the early adopter. And
yeah, exactly. So the first month was super slow. And then like 2 or 3 months in, like views started picking up. And I started noticing that people from outside Stanford were watching these. And I started getting like requests saying, hey, that video was awesome. Can you do a video on this topic or that topic instead? And I was like, okay, I guess so. And I started, taking more requests, putting more videos out. And, the first year still started out pretty slow, and then started hitting my stride with more and more views and more subscribers. And then it took off from there.
Dude,
so it was very non-deliberate.
Non-intentional.
It was non-intentional. It was just, I did not expect to be here 8 years later. I expected to put up like 5 or 6 videos, and that would be it.
Dude, this is a crazy story, because you saw a need. You said, I could make it a little better. You used YouTube, which is a new technology, and said, oh, you know what? These lectures, if they can't come, I can do it. And you were ahead of the Pareto distribution, so you were one of the early adopters, so the views beget views. The next thing you know, you're getting better and better and better at doing it too, right? Because you probably honed what's happening. Because now you have 277,000 subscribers, and that bumped up by like 17,000 subscribers or something in just like 6 months. Like people, it's a huge outpouring of subscriptions because people find value in what you're doing. I mean, did you even... this was not your intent. Why do you think this happened?
It was sort of coincident with the rise in the flipped classroom.
The flipped classroom, right?
Yeah.
So exactly.
And the rise of people starting to. I mean, this is not something it wasn't news in 2011, but it was maybe news to like the higher ups that like having these old school lectures where there's like 100 kids or students. Not kids necessarily, 100 students in a large lecture hall, and they get the stage on the stage going through like PowerPoint after PowerPoint for an hour at a time. Like that was not very effective.
Yeah.
At actually imparting information that was going to stick more than 5 seconds. And it was sort of around the same time that medical schools sort of wised up to this as being like not the best strategy. And so they started to incorporate more videos sort of in their curriculum and started encouraging students to look at videos. And this is also the sort of the generation that grew up with the internet,
right?
And not just the internet 1.0, but sort of grew up with, a lot of these students had like, for example, Khan Academy, they might have used in high school or college,
right?
And then they get to medical school and they see things like my channel, there's other channels as well. That's sort of like a natural extension of that experience that they had with the platform and learning on that platform in their previous life as an undergrad student or a high school student.
That makes perfect sense because it's funny because what you and I do are they're very different, but they share certain commonalities. Like I imagine with your audience, a lot of them are watching at like 1.25x speed.
Yeah, 1.25x is slow for my audience.
For your audience.
Yeah, most of them watch at 1.5.
1.5.
I guess, yeah.
And that's how I consume YouTube content as well, because I've noticed there are people that consume at different speeds, right? So I like to consume at T1 Ethernet speed, and I demand my medical students present as fast as and as succinctly as they can, because that's my style of reception, right? Everybody's different, and the wonderful thing about YouTube is they can choose the speed of reception. When I would sit in the sage on a stage platform in medical school, it was too slow. I had too much ADD. I couldn't rewind and do all of that, and so I walked out. So I never went to class after the first few, and that put a lot of pressure on me to study at home and on the last minute, and it just created a lot of suffering for me. Also, a lot of disengagement from my colleagues, my classmates,
Yeah,
who I began to resent because I was like, I don't understand you people. Like, why are you, how can you sit and listen to this person drone on and on and on? And so to me, what you're doing on YouTube resonated a lot because like, if I had this when I was a medical student, I might have actually, you know, I probably wouldn't be doing what I do now because I would probably have been some academic, better trained physician gone into some esoteric subfield. And so, you know, looking at your stuff, did you ever, okay, because this is a thing that people worry about. And you said something early on, you said, nowadays it seems like it's much more deliberate. There are a lot of medical students who are trying to get famous.
Yeah.
There are a lot of kind of residents who are actually legitimately famous, who have made an attempt on YouTube to do the YouTube thing, which is the thumbnail that looks like this. 20 reasons why gout can hurt your toe.
Yeah.
And they're just like, and it's gamified, it's clickbaited. I try to watch some of those and I'm just perplexed.
Yeah.
But they're insanely popular.
Yeah.
But what you're doing is actually a very conservative form of teaching. You have images, you have you lecturing. It's clear you've prepared. Do you spend a lot of time preparing each of these, and how do you prepare?
Yeah, so I definitely spend a lot of time preparing. I probably put, if I were to make a 15-minute video, that would be at least 15 hours of work.
What?
Yeah, 15 hours for 15 minutes would be typical.
Okay, so explain to me what you do to make that 15 hours, because I think there was a question on Twitter. How much time do you spend preparing? How do you prepare? What do you do? Do you do it all yourself? Just walk us through your process.
Yeah, sure. So, the first step is to pick a topic.
Yeah.
And at this point, most of the topics come from subscriber requests. You know, someone will just put a comment after at the end of one video saying that video was great. You know, I would love it if you could talk about this topic also.
So they have a real voice.
Absolutely.
Yeah.
Some of them have like curricular needs at Stanford. Like if Stanford has like a gap where there's some topic is really not being covered in as much depth as it probably should. I might be like, oh, I recognize that gap. Let me make a video to fill that in. So I pick a topic. Then I have to research the topic, and you know most of the things I talk about, and I try to make a very I try to be very deliberate about this part, is that I don't talk about things I know nothing about.
Okay.
So
you don't try to go learn something that you've never.
No, not de novo. Like so, for example, I get people saying, "Oh, hey, can you talk about preeclampsia?"
Yeah.
And I say,
"Not my
no,
thing."
I can't. Like I'm not an obstetrician. I can't talk about preeclampsia. You don't want me talking about preeclampsia. I don't know enough about it to impart my knowledge, because what I'm trying to do is I'm not teaching laypersons. If my target audience was laypersons,
like Dr. Mike, say,
like Dr. Mike,
right?
Then okay, like I feel like I could, between what I know from medical school,
right,
and what I can read about right now,
up to date,
and what I get from up to date, like I can put together a 5-minute video on preeclampsia that I feel happy with, if the target audience is laypersons,
right,
or pregnant women,
right.
But if my target audience is like internal medicine residents, or if my target audience was like obstetrics interns, like there's no way that I could be talking about an obstetrics topic from my own experience. Like just it would not be appropriate.
It's funny that you say that, because I've talked about a lot of different things, and I try to research as much as I can, but I'm not experts in really anything except for the hospital medicine stuff. And even that, it's like sketchy, right? Because I'm ZDogg. I'm like, I don't know. But my audience is like healthcare professionals mostly, but a lot of like kind of activist engaged patients and other people. And so it's a broad, and the difference between teaching, say, a certified nurse assistant and a attending electrophysiologist about atrial fibrillation is two orders of magnitude, right? And it's understandable because that's not their space, but it is their space. And so I have to try to find a sweet spot. You are assuming from the beginning that you're teaching doctors, basically, medical students.
Yeah. So my target, I think about my target audience as healthcare professionals in training.
Got it.
So that could be medical students, that could be nursing students, that could be PA students, that could be interns, that could be an RN that's now going back to school to get a degree in to be an NP. That's sort of my target audience.
All of them.
Are there laypersons that watch yes, I know there are laypersons that watch my channel. Are there attending physicians that watch my channel? Yeah, I know they are. Yeah. But my target audience is really the healthcare professionals in training, from first year of professional school up into the last year of residency, or the residency equivalent for people in fields other than than physicians.
And so when you're preparing, and that's fascinating to me, because that's not an area that I focus on. So the fact that you do it so well, and when I look at your videos, like how to create a differential diagnosis, what is a normal heart rate, like how to interpret a chest X-ray, and that has 685,000 views because everybody who's in training needs to know that.
Yeah.
And intro to EKG interpretation, a systematic approach. Holy crap. I would have loved to have that when I was a medical student. And here it is for my level of training. So in other words, like if I'm a medical student, if I'm a resident, it's pretty much the same. You really need to know that level of teaching. And that's what is so special about what you're doing that made me go, oh, wow, because you're a schmo like me from Stanford that, like, you know what I mean? Like, we're both hospitalists. How is it that we can tell other people in this community that they can be empowered to do something well beyond the confines of the walls of a hospital? And I think you're showing people how to do this. Like, you know, I don't imagine that you were formally trained in teaching, right?
No formal education background. No.
And were you formally trained in video?
No, most certainly not.
And so in this 15 hours of prep, what is that? How do you go about it? What's your process? Then once you pick the topic,
pick a topic, then I got to research it. Research for most topics usually starts with up to date. It doesn't end with up to date, but that's sort of like my go-to if I want to, like right now, for example, I'm doing one on shock, or sorry, not shock, sepsis is one I'm working on right now.
Nice.
And
I did a music video on that. That's the difference between us. It was beginning to look a lot like sepsis.
Well, I'm guessing yours was more fun to make than mine.
It was a lot of fun, but probably as much work.
Yeah, no, I don't doubt that.
Yeah. But please, so you're working on sepsis.
Yeah, so I work on sepsis. So I start with up to date. From up to date, then I branch off and I'm like, oh, well, I got more interested in this topic or that aspect of it, or this thing that I see in real life isn't covered in up to date. This thing I hear on Twitter, like people on Twitter talking about vitamin C and sepsis, like that's not discussed in the up to date article. Let me like pull up some papers about that.
We had Merrick on the show.
Oh, really?
Yeah. He's quite a character. He's a real maverick. Yeah.
So then, try to broaden, how much I understand the topic, trying to incorporate then into, and then I write a script, incorporating my own experience.
Wait. You write a script?
Yeah, I write a script.
So you actually have prepped out what you're going to say. God, that's awesome.
Yeah. Well, the problem with not writing a script, because some people who do medical YouTube videos don't write a script, and what happens is like they leave things out.
Yeah. It happens to me all the time.
They misspeak, and if you misspeak, like in a casual conversation, like if I were to say something stupid right now, like it's not the end of the world. Like maybe like I'll look like an idiot, but like a human being's care is not going to be compromised because I said something off.
I'm feeling very uncomfortable.
No, but if I'm talking about like what's the appropriate antibiotic coverage for a certain disease, and I give the wrong antibiotic because I have a brain fart, that could be a problem.
Absolutely.
So I have to write a script out, then I have to proofread the script. I have to, if it's a topic that I don't feel 100% certain on, I get someone else's eyeballs on it just to make sure.
It's almost malpractice if you're teaching the wrong thing, right? If you make that mistake.
Because, I don't know if I'd call it malpractice.
Well, no. Okay, let me pump the brakes on that. Malpractice is a trigger word for us doctors, meaning it's a kind of educational malpractice because you're misleading or you're misinforming people that trust you.
Yeah.
And I think you take that very seriously with the amount of prep you're doing.
Yeah, I certainly do. I mean, do I make mistakes from time to time? I do. I feel awful when that happens.
But you correct them.
Yeah, so depending on the magnitude of the mistake, I'll either put like corrections in the description of the video, like, hey, I at 15 minutes and 32 seconds, I said hypokalemia instead of hyperkalemia.
Yeah.
It's usually evident from the context that I made that mistake to anyone who was actually paying attention. If a mistake is really bad, then I like take down the video. Like if someone points out, like, I totally misunderstood this certain study, I look at the study, I'm like, oh shoot, like you're totally right.
Yeah.
Take down the video, fix the problem, re-upload it, which of course stinks with like the analytics and stinks with like the algorithm and whatnot. But
it's more about doing the right thing.
Yeah.
And I mean, don't let me forget to ask you about algorithm metrics and how it's destroying our brains as creators, right? This has been a couple shows I did recently about how I'm so burned out looking at this stuff. We are slaves to these algorithms and metrics. If we don't put out content regularly, if we don't game it in certain ways, if we don't share it in certain ways, if we don't promote it in certain ways,
we don't have the thumbnail that's
exactly
the
right
clickbaity title.
Now, see, it's interesting. So, Dr. Mike, he's a good example of like probably the preeminent YouTube doctor right now. He has all that. So he has the looks, he has the thumbnails, he has the team to help the editing, he has the content that's aimed at muggles, non-medical people, and he is crushing the game, like absolutely doing amazing. And you know what? I met him, I interviewed him. He's a good, sincere, wonderful person. And so I'm so happy that he's doing that. It's a different space. And what he's doing is he's using those tools to reach young non-medical people and educate them about health topics in a way that Dr. Oz has dropped the ball on, right? Yeah. So that's wonderful. But what you're doing, so with all this prep, with writing out the script, with making sure it's academically appropriate and correct, well, then what's the next step? You've written out your script.
Well, then I'll make images or figures, diagrams to sort of go along with the script.
Do you pull them off the internet, or how do you?
I would say 90 is a made up number. 98% I do myself.
You create the diagram.
Most of them, and if they're not, they're cited. If you see something on my channel that's not cited, it's because it's original.
So I'm looking at these diagrams here, and they are extraordinarily complex PowerPoint style diagrams. You make those?
Yeah.
That's incredible. That's actually a real skill. So that's something you're bringing to the table that, say, I don't have at all, and a lot of people on YouTube don't have, or they outsource it or something. You're doing that all yourself. That's a huge amount of work. Now I'm starting to see where these 15 hours.
Yeah, that's definitely a large part. Like that's probably 15 hours. That's 4 or 5 hours of me making like half a dozen diagrams.
Oh my gosh, that's insane.
Yeah,
well, I'm really in awe of you. So you make these diagrams, and then what's next?
Well, then I gotta record it.
So how do you go about that?
Yeah, so recording process. So anyone that goes to my channel will see that I have sort of three different setups. One setup is with no live action, so it's not me. You don't see my face at all. It's just it looks like a sort of like a narrated PowerPoint with some a couple of simple animations thrown in, and that's really something I just done on the computer with a mic similar to this one, like a USB mic plugged into the computer, and that's pretty low key to create. Those are much faster. Another sort of the next level setup is where I'm in my office and with the books in the background, and for that I basically just bring in one softbox light, which is usually, to be honest, too bright. I don't realize until it's after it's recorded. And I have a mic on a stand, and I record it. Usually it takes like 2 or 3 takes to feel good about it.
Are you using a green screen or?
No, for the ones and with the background of the books in my office, like there's no green screen.
That's a real thing, but I'm looking at some where it's like you're against a white background.
Yeah, so that's the one that's the most time intensive because that's in front of it looks like a green screen. It's actually a white screen, but it's that takes a lot of prep because I don't have a space to record this, and we have we still live we're in the Bay Area, so that two physician family, we still live in like this tiny 1,300 square foot apartment, and we don't have any place to record it. And so what I have to do is, in order to record those videos, I literally have to take every piece of furniture in our combined living room, dining room, family room area and pile it all up in the corner. It's like all literally stacked on top of each other in a corner to make enough space to set up like the sets of lights and the overhead mic and get the giant screen up to record it. And that takes it's like a 2-hour setup for that. And then record it. And then it takes so long to set everything up that I either spend the entire day recording like one 10-minute video, or I just leave everything up and then just like record a bunch of videos back to back on either record 4 or 5 videos in one day if I'm really on the on the ball, or sometimes I'll have to keep it up for 2 or 3 days, and my wife will come home and open the door and be like, "You got to be kidding me." Like, where are we supposed to eat dinner? Yeah. I'm like, the floor works fine.
I've had that conversation with my wife.
We have a bed upstairs. We can just have the kids just hop on the bed and eat.
That dude, that story, the nature of your diligence is really astounding, man. Because it's like that. Because I know I did the same thing.
Yeah, I'm sure it's very similar to
thing. You're in my garage right now of the house where I started ZDoggMD back in 2010. Yeah. Before we remodeled it and stuff. Right above us is a little tiny little bedroom that I had converted. I'd put a green screen up. I had my computer for editing. I had my little handy cam on a crappy little tripod, no microphones, and just like, okay, guys, I'm ZDoggMD, yo. And it started like that. Yeah. And the thing is, it probably could have continued like that if it was the right material. And over time, it just kind of evolved because my audience, and moving to Vegas and stuff, the expectations started to change, and I wanted to grow that more produced feel because of the music piece of it.
Yeah, you can't record videos in your bedroom upstairs, I'm sure. Like the music videos.
I've done it. So I did a video called Hard Knocks Life. That was a Jay-Z parody. I recorded it in my closet with GarageBand. I put up a green screen, so people are like, oh, we recognize scenes from Stanford in that video. You must have gone and shot at Stanford. I'm like, you think Stanford would ever let me shoot? Are you kidding me? They're the most risk-averse people on the planet. So what I did was I snuck in when I was rounding. I had my little handy cam in my doctor's coat pocket, and I'd pull it out and I would just shoot the escalator, or I'd just shoot a backdrop with no patients in it, and then I'd green screen myself from my bedroom into that, going, it's the Hard Knocks Life for us, and I do a few tricks in Final Cut and make it look like a real music video. But it was pretty ghetto. And
anyone from Stanford ever like see that and reach out and be like, dude, when did you record that? That was not okay.
This is the beautiful thing, dude.
Like no
in
one
those
noticed.
days, no one at Stanford was on YouTube watching stuff. Now it would have triggered all kinds of legal, summons. But in those days, nothing like that. And just like when you were starting in 2011, like YouTube was a wild west.
Yeah.
Like I remember feeling like, man, I could almost put anything out on YouTube and it's going to get a few thousand views just by showing up, because nobody in medicine is doing this.
Yeah.
And now it's good because it's a crowded space. Only the best content's going to come to the top, and your content is really amazing. And so then how do you are you reading from a teleprompter? How do you get your script out?
Yeah, so I have this super basic teleprompter set up. It's like on my iPad. There's like a teleprompting. You probably have seen something similar.
I've seen that.
It's like a teleprompting app. And you put the iPad on this little stand, and it's hard to describe, but
I know what you're talking about. Yeah, I've never used it. I've seen it, and Thomas my producer tried to get me to use it, because he's like, man, when you do your rants about whatever, if you just stop forgetting stuff, because we never edit them, we just go in one take. You wouldn't have to do 30 of them, and then we always end up taking the first one anyways, even though it's incomplete.
Well, so the problem with the teleprompter is you can't go off script.
Yeah.
Like, because as soon as you go off script, the teleprompter, some are timed. So
auto advanced,
auto advanced, and some are voice recognition. But as soon as you go off script, like either one of those gets, you have to give up. Like you can't do it, because then you have to go back and reshoot it. And so you have to stay super strict to the script. And so the problem with that is if you're thinking of something, if in the moment you are recording, you're like, oh, I totally forgot that point. I wanted to add it in, or this sounds too canned. Let me like add this little aspect of like my own clinical practice. The game's over. You can't do it. So you have to stop everything. Pull up the iPad. Edit the script in. And then the other challenge to doing it off the teleprompter is to try to make it sound like casual, make it sound not read. Which and I'm like the first handful of attempts at this were like a disaster.
Yeah,
like I was just like. And so if you want to estimate the central venous pressure, like it sounded like a robot, and it took a while to get used to using it.
The teleprompter.
Yeah. And I'm sure like there's still like times when I'm sure I still sound like a robot on it, but hopefully I'm incrementally getting better.
Your videos, I went through the sequence, and they're better and better and better. But what's interesting to me though, this is interesting because it makes sense that you're using the teleprompter, and I know why you're using it and why you have to use it. It's important, right? Because it's teaching. But I can tell right away that you're not. This is not an improvised discussion, because I contrast it to how I do things. And there's a big part of me that's like, I wish I could do what you're doing, because it would allow me to be much more complete and careful. But then there's a bigger part of me that's like, my audience doesn't want that from me.
Yeah, there's a lot of value, I think, in being more spontaneous and feeling it's more real, rather than something canned and prepared. Like there's advantages, disadvantages, and you really have to, as you said, you have to go with what your audience is wanting.
But and this is another reason I want to have you here, because I think it's fascinating to get the contrast between us, because here we are talking, you're like absolutely spontaneous and natural and open and not guarded in any way. But if I would just watch your videos, I'd be like, oh, this guy's it's gonna be intense. Like I'm gonna have to try to pull him out of his shell, right? And that's great, because when you're actually teaching this material, like, yeah, we want it to be fun and stuff, but at the same time, if it's not accurate and you're teaching people who are touching lives, right? Yeah. That's it's just dangerous. And it's something I think about quite a bit. And the problem is I have also a team that pulls me in the other direction. So Tom and Logan on my team are like, fuck it, dude, just go off script. Just tell them how you feel, Z. I'm like, medicine is not about necessarily how I feel. I can say how I feel, but we still have to do the right thing. And one thing looking at your videos that always reminds me, I'm looking at this shit going, surface tension and surfactant, fluid mechanics, lesson 12. You know, let me see here. The ABG interpretation, interpreting pulmonary function tests, mechanical ventilation. It reminds me, and sometimes this bears reminding, that medicine is so complex. Is that what motivates you to do this? Like, why? Because here's the other question. Like, why do you do this, dude? It sounds painful.
Yeah, it's time consuming. It's not, I wouldn't say it's painful. Like, there are certainly painful parts to it. Like having to rearrange our entire home to record 5 minutes of video is painful. But the process, overall, I really enjoy it. I think it's a couple of things. One is knowing that I'm helping people learn the material in a way that wasn't available to us when we were students.
Do you get feedback to that extent?
Oh yeah.
I bet you do.
Yeah, I get emails. I'm sure you get emails and messages and you know.
From anti-vaxxers wanting to kill me. Yeah, I get that.
I haven't had that pleasure yet.
Do a thing on vaccines.
Yeah, no, I've specifically stayed away from that topic.
I imagine.
For that reason.
It's a good idea.
But no, I get these messages, and I mean, it's like an ego boost. I mean, to be honest, like, and I'm sure you get that as well. There's also this sense of, you know, as an academic physician, you know, you are expected to do something beyond just clinical care. Like, clinical care is great, but even as a clinician educator, a CE, you know, which I am, you're still expected to contribute to the general broader medical community beyond your specific patients, and even beyond the people that you're teaching in real life. And most people sort of fulfill that obligation by publishing. You know, they put out papers, either clinical research or review papers or some type of other peer-reviewed scholarship. Some people fulfill that role by serving on a national committee for a professional society, or for a committee that's putting out new guidelines on a certain topic. And I see my role and the way I fulfill this obligation to contribute something to the broader medical community as just putting out these YouTube videos. Like, that's my contribution.
Oh, there's so much here.
Yeah.
Man, I want to go through everything you said and unpack little pieces of it, because this is such an important part of this conversation in my mind. And that is starting with the ego boost. Yeah. Getting these messages. Like, this morning I read a message that literally made me cry. Like, I was crying, because this person was pouring out why what we do is important to them in a way that was so moving, because it somehow put a finger on why I did it, and I didn't even know why, because I've been suffering through this, you know, creator burnout, which we'll talk about. But and so you feel this, you know, this like depersonalization and lack of accomplishment, and it has to do with ego. It has to do ultimately, I think, with this feeling that I'm not good enough to do this, or I'm not making a difference, or people are better than me, which is a horrible feeling, right? Especially when we're so achievement oriented, and you know, and so getting that feeling of accomplishment from making these videos, putting them online, and having an impact in the world is something I think we should own. We should say, yes, that is a part of it. Like, it does feel good to be appreciated for something that you do well. Yeah. And what you're doing is amazing. I'm appreciating you now.
Well, thank you. I have appreciated your musical videos and your other videos for many, many years.
Why, thank you. And so it feels good. At the same time, there's something even beyond that, which is what you said, the feeling of, oh my gosh, people are being helped by this. They're sending emails. They're saying, oh, this helped me understand this concept, or I did better on my test, or I got into nursing school or medical school or whatever because I watched your videos and I did better on the MCAT, or whatever it is, right? Those are wonderful reinforcements. But then there's the practical aspects. And this is what I want other doctors and healthcare professionals, everybody to know, that there's an academic advantage to this. So Scott Weingart, who I don't know if you know him.
No, I don't.
So he's somebody I'm going to introduce you to. So he is a wonderful human being. He's an emergency physician and a critical care physician. So M-Crit is the name of his podcast.
Oh, yeah, I know M-Crit. Yeah,
you know M-Crit.
Yeah,
right. Yeah, so the man behind the mask is Scott Weingart. He and I became friends early on in 2010 when I started making music videos, because it was such a small little community that we all reached out to each other. You know, Rob Orman and all these guys. Rob Orman does ERcast. Wonderful human beings, teachers, inspired by inspiring other people to learn. And Weingart made it an academic issue where having an international reputation, as he does online, helped his career advancement in academics.
Yeah.
And it should, because you are actually affecting people in some ways way more than an article in a one-off journal. I mean, I'm not going to lessen that stuff, but like way more than going and presenting at some conference at a poster. You're actually really transforming education, affecting lots of people, and you should be rewarded in academics for that. Now, have you found that to be the case?
I'm gonna have to get back to you on that.
Yeah.
So I'm currently being considered for advancement.
Yeah.
And there's a discussion about whether or not this should count. So I'm gonna have to get back to you. I'm supposed to hear it any day, to be honest.
Can I say something? And this has nothing to, there's no reflection on you.
Yeah, sure.
If they don't consider the body of work that you've done on YouTube, the impact that you've had, the number of people you've reached, the diligence and the quality of the education, they should go and stick it in their ass. Because, and again, you're not saying this, I'm saying this. It is the single most important thing, I think, is to affect other people's learning as an academic, to advance this. And you've done that in spades. And again, this is me talking. This doesn't reflect on you at all, because I don't want to get you in trouble. I'm just
I have
saying,
nothing to do with this whatsoever.
Exactly.
This is not me. This is all Zubin.
Listen, I know that Stanford are good people. I know because I've worked with them, and they will. They are ahead of the curve. They're in the Silicon Valley, but I know a lot of entities that don't recognize this, and I'm really talking to them. I'm saying, if somebody like Eric Strong, who's a great doctor, does this amazing diligent work and reaches all these people, that should be recognized as an academic accomplishment, particularly in a clinician educator line. I mean, you're not an MCL line or something where you're supposed to publish or perish. This is, and even if you were, this should be part of it. This should be part of it. So I would like to advocate more, I think increasingly with the show, for transformative change. And transformative change is encouraging our academics, our thought leaders and our teachers to teach using new and engaging mechanisms. And if that means that some kid, it's funny how both of you and I call them kids. Like, well, the kids are watching this.
Yeah, I didn't mean to say
No, but it's true.
Don't mean to offend anybody.
To me, a 35-year-old learner is a kid.
Yeah.
You know, and so if we're, we want to encourage these kids to use this technology at their own pace. So if that means 1.5x watching Eric Strong videos, and that works for them, then it should work for them. I mean, do you what's your gut on that? Do you think that change is coming?
I think so. I mean, is it going to impact me in this decision that's coming any day? I don't know that. Hopefully it will, but I don't know.
Well, we're giving you an international reputation right now. All right.
I'm actually gonna addend my application with a link to this interview.
Yeah, and then you'll be fired outright. It won't even be an advancement issue anymore. I love it.
But the change is definitely coming, and whether or not it's now, whether or not it's a year from now, 5 years from now, I think people are increasingly recognizing the value in this space, whether or not it's YouTube, whether or not it's Twitter, whether or not it's some other online space, blogs, podcasts, etc. Like, for example, I don't know if you're familiar with Tony Brew. He's a hospitalist at the VA Boston.
I don't know Tony.
He is the master of something called the Tweetorial, which is essentially it's a short form intended to teach a very, very specific topic in a span of anywhere from 5 to 15 linked tweets. And he's been doing this for a few years, and he's not the only one. There's lots of people that put out these tutorials, but he's sort of like the king of them right now. And he actually had an article in the New England Journal like 3 weeks ago talking about tutorials and why tutorials are this really great way to get to educate physicians, educate learners why it's a really great way to get people motivated and interested, not just to educate them, but get them interested in self-directed learning again, because the format is much more engaging, it's much more real-time, it's much more collaborative, where you can talk back and forth with people and have a debate and discussion right in real time online. And I mean, this is a major highlighted article in the New England Journal. And you know, I like to think that, I mean, I've never met, you know, Dr. Brew myself. I like to think that his standing in academics is influenced and is helped by everything he's done, all his work on Twitter. Because he's super well known in that space. Do I know I mean, I have no idea. It's very possible that his institution doesn't value it, which would be shocking and really unfortunate. But I think that just the fact that, again, he was able to get this article out, just the increased recognition, I think people are starting to wise up to the fact that this is like social media should play a role in physicians' professional lives, and it should play a role in how we're valued by our institutions.
You know, I'm with you 1,000%. Weingart is a real expert on this and has spoken about this, and I think it's.
And I will say, because emergency medicine, is definitely they're way ahead of everyone else. Way ahead of us. Yeah, you know, and they've been ahead of us for years with this.
You know what's funny? So as a hospitalist, it's our tendency to want to hate on those guys, right? Because spandex, North Face jackets, and admissions. But they are absolutely brothers from other mothers who are way ahead of us in terms of that stuff. And so when I started in 2010, it was the emergency physicians that were blogging and doing podcasts and things like that that embraced what I was doing, that brought me into their tribe, that schooled me on a lot of things, that helped me. And in a way that I'm still immensely grateful. I'm still good friends with them because they gave me that shot to do this right. And I think that's so important, having colleagues in this space. And, you know, it's another secret reason I wanted you here. There aren't many people that I can talk to personally about what the stuff we do.
Yeah.
Like when you came into the garage, we only spent 5 minutes kind of warming up before we launched into the thing. But you were like, you got to tell me about this equipment. And I'm like, I couldn't imagine a conversation I'd enjoy having more than a fellow doctor who makes YouTube videos and me going, okay, so here's how we light this scene. Or this is what I found about this mic.
Dude,
like,
lighting is like the worst thing for me. Like that,
dude,
it's like the vein of.
Here's the thing though. I'm looking at your lighting. Yeah, it's a bit overlit in the front.
Yeah, some of them are definitely overexposed.
But some of them are perfect, and in general, you look fine. With me, lighting is so important because I get these dark circles under my eyes from a combination of genetics, being Persian, and lack of sleep. And so if you don't light me right, they're distracted in the comments. They're like, you look like you've been poisoned by toxins. And so... See, the way I see human visage is we're an icon on a graphical user interface. Reality is just a series of icons. The real thing is we're all just conscious agents. I won't get into that.
Yeah, but I remember that talk.
You remember that talk, and you're probably like, next. And but the truth is, those icons matter if you're trying to influence and educate and entertain people. So that's why lighting matters.
Yeah.
That's why audio matters. Because if it sounds shitty, people don't want to. And this is the thing. Like, I see a lot of people send me videos. Oh, I did a parody, man. What do you think?
Yeah.
And I'm like, I think it sounds like shit. I think the lyrics are dumb. I think you look terrible in the video, which means you didn't light it right because you're a good-looking person. So here's my feedback. Fix all those three things. They're not that hard to do.
Yeah.
It just takes a little bit of training. But who's doing the training? You know, you can watch YouTube tutorials. You can do things like that. But sometimes it's good just to talk to somebody who knows what they're doing. Yeah. And so it was really cool to have you come and have us talk about it. That relates to this. Haters. So do you get haterade on YouTube? Like, do you get comments where it's like, you're a dumbass, or, you know, whatever it is?
Yeah, that's a great question. I don't, with one exception, and I'll get to the exception in a second. So for the most part, like, I can, if I made anti-vax videos, videos about not anti-vax, but videos about anti-vaxxers.
Yeah, please don't make anti-vax videos. I think the conversation would be over pretty fast. Yeah.
I definitely would get tons of hate about that.
Yeah.
But you know, ECG interpretation, you know, hyponatremia, they're not controversial, emotionally heated types of topics,
aren't they?
They really aren't.
Okay, because I get real. I've done talks on hyponatremia, and I get angry about the way sometimes it's misunderstood.
Well, you can get, but like I don't get, like people don't like respond to my my video about shock being like, you're such a freaking moron, Strong. you should go back to high school. Like no, like people will be respectful. They'll point out things that like, hey, I think you misinterpreted that.
Sure.
Or like, oh, I haven't found that test to be as important as you're implying it. Like And
I want your fans. I want your fans.
Well, I absolutely want that kind of feedback. I want to know, like, I want people to share that kind of feedback if they disagree with me. Like, absolutely. Like that's not hating me. Like that's helping me get better, be a better physician and be a better communicator and be a better educator. Like, I want to know that kind of feedback. But the comments like, you're a dumbass, like, I don't get those, with the one exception. And the one exception is I made this video about 2 years ago, and it was on the diversity of sex, gender, and sexual orientation.
Oh, that's not controversial.
No, not controversial at all.
Yeah.
And it wasn't meant to be like, it wasn't like an advocacy video. That wasn't, not to say there's anything wrong with that. It just wasn't the intent.
Yeah.
The intent was more like, let me introduce the terminology, because a lot of students
don't understand.
They just don't understand. Like someone says that they're transgender.
Yeah.
Like someone describes themselves as a transgender man or a transgender female or a transgender woman. They might not know what that means.
Right.
You know, someone describes themselves as queer. Like, what does queer mean?
Right.
Like, those words are not universally understood by a lot of our students and a lot of students around the world. And so my intent was just to talk about the terminology, talk about sort of the diversity of what people's experiences and emotions and sort of how they identify is. And it was sort of more like, it was relatively academic discussion. But there was like a ton of like hate comments on that. Like, oh my gosh, like there's only 2 genders. Like, what are you doing teaching this garbage? I had like response video that was posted where they went through like point by point.
Oh my gosh.
It was a little bit creepy actually. But that was the only hate video.
You know what? That's your first brush in the Venn diagram with me. Really, because you know, you're this diligent educator who does it by the book and doesn't get hate, gets constructive criticism. That's where you cross into my Venn, where it's like, let's talk about something that really does poke the moral palate of a certain segment of the population.
I can't imagine what topics that you could have covered that would do that.
Let me see. We've done abortion, vaccines, guns. The only thing we have...
Pain addiction.
Chronic pain. Right. Oh my gosh. I've had death threats from people with chronic pain. Just by saying that, like, listen, opioids are not the answer for most chronic pain. Well, wait. Is that a controversial thing? Well, it is to people who are addicted, dependent on opioids for something that started out as pain, but now it's maybe opioid hyperalgesia or something like that. So, but how do we handle that hate is very important, and it reflects on us. And I think there were times when I've handled it very poorly, and I get into the melee, and it's fun for me sometimes. And then there's times when I realize, no, this is leading to more burnout for me, because we are negativity focused creatures. We will pick out the bad and ignore, discount the good. It's a common way that our brain works, and it's designed to keep us alive. Like, look, if there's a poisonous berry, let's focus on that. But whereas we don't really focus on the positive social connections we have, or the wonderful relationships in our neighborhood we focus on, oh, there's this one guy, man, and he just has his El Camino up on blocks in the driveway, and he's bringing down the property values. You know, that's how we are. So social media can be dangerous that way, and that leads me into this question about burnout. Are you getting paid for any of this stuff?
So I don't get a salary from it. So about half my videos are monetized, which I'm obviously, you know about that. But for people that are watching this or listening who don't know, essentially that means that I've given YouTube the permission to put ads either at the very beginning of, like, banner ads at the beginning, or like an actual, live action commercial that you can you're like, all right, 5 seconds. When the 5 seconds up, so I can skip this.
Sometimes those commercials are compelling, though.
Sometimes they are.
Sometimes I'm like, ooh, that movie's coming out. Or, ooh, I could enlarge my penis. Well, maybe.
The irony.
I meant to just think that.
The irony is that the algorithm that decides what videos to show in front of your video, what average, it's so off. Like, I have a video that talks about quackery around fungal disease, right? About like things like chronic candidiasis.
Right.
And if most of the time, if you watch that video, if you click on it, the ad that will come beforehand talks about like treatment for like these quack diseases that don't really exist, which is just, I find kind of amusing.
It's funny. I get a lot of weird, like, alternative medicine stuff when I'm talking about science. Like, those will be the ads that come up. It's strange. So you monetize partially through the YouTube ads.
Yep. And then so about half the videos are monetized. And so then since YouTube's owned by Google, then Google sends me a check or once a month, and I'm sure you get something very similar.
Same thing.
And it's not pocket change. It's like a nice amount of money. But I'm not retiring. I'm not like giving up my doctor job anytime
People
soon.
don't realize it's not that much money.
No. I mean, compared to how much work
is a physician's work hour, like our opportunity cost. It doesn't pay for it.
No, not even.
You're 15 hours of time, and you're full time.
Full time, yeah.
Full time.
Well, It depends on how you
parse up. Because some of it's academic time.
Yeah, exactly.
Exactly.
It's functionally full time.
Exactly. Yeah. Yeah, because I remember when I was doing it when I was full-time hospitalist, and I was working 120-hour weeks, and including the videos and all that, and it was exhausting. And that brings me to the burnout question. So you have you're not really getting paid, Eric. Like, you're not getting compensated for your time.
Not so remotely.
Not even remotely
to what the opportunity cost is. You put
exactly.
Yeah.
You do it because you love it. You told us why you do it. I'm with you on why you do it. So, do you feel like with now all the changes in the algorithms and how much we have to push, and have you been affected by that, or are you just tuning that out? Like, if you do a video that gets, let's see, like 3,000 views versus something that gets 13,000 views, do you feel that in a negative way? How do you respond to this? And I'm asking for a friend.
Well, a reason that my circumstance may not be directly translatable to yours is that not every topic is going to be equally compelling. And I mean, I'm sure that's true. I mean, I'm sure that's true for what you do.
It's true on mine too, but see, in my mind, they're all equally compelling, and that's the problem.
But in my mind, I know they're not, right?
Yeah.
So if I do a video on like how to interpret an elevated anion gap acidosis, like I know that's not going to be as compelling as how do you interpret a chest X-ray?
Right.
And so if the elevated anion gap acidosis gets fewer views, which I totally expect it's going to, I expect that. That doesn't hurt my feelings. I don't get bummed out about that.
Right.
If I make a video that I think is really awesome, and that does poorly, relative to that hurts a little bit. And you try to understand either from the comments or from the analytics, like why that video was off a little bit. And you sometimes you can parse it out, and sometimes you can't.
I find the self-insight on those failures is very hard.
It's really hard. Yeah.
Like I'll put so much effort into a music video, say, and then it will just not do well at all. And I'm like, I thought that was a good video. That really hurts, And then there's some videos where I'm like, I know this isn't a great video and it's only going to do okay. And then it goes viral and you're like, like I did Ativan. It's this parody of this horrible mumble rapper guy, trap music. And I was like, this sucks. This is terrible. 6 million views on Facebook. I'm like, God. And then I put so much blood, sweat, and tears into One Seek, which was our Bare Naked Lady parody.
That was really good. I like that one, actually.
I'm glad you did, because most of the public was like, huh? And they were scared to share it because, is it racist? Yeah. And so it's kind of like, meh. And I'm like, oh, this was my labor of love. But you know what? You have to, it's an ego thing.
Yeah.
You're like, this is what I love. Why doesn't everyone else love it? It feels a little...
Yeah, no, it hurts a little bit. I mean, I had this one existential crisis on YouTube that happened in February, actually, just this past February, where looking at my analytics, and I don't go to analytics every day. Like, it's not something that drives how I approach YouTube. But every once in a while, like once every week or two, I look at it to kind of get a sense about which videos are doing well and what are some things I might need to tweak. And back in February, there's this trend where I get X number of subscribers, new subscribers every day. And then it literally overnight went from X to like X divided by 2.
Yeah.
And it was like a very, very clear like step down trend. And it wasn't just a one-off day. Like it was, and it's continued now. Like if you look at my number of subscribers per day, it's after the stepwise trend down, it's different. It's completely different than it was in previous years. And there was no explanation given. Like I couldn't, like I looked through the analytics. It didn't make any sense to me, like why that happened. I reached out to YouTube because, as you may have a YouTube creator, I forget the name, manager, whatnot, that YouTube provides, and they had no idea.
Figure it out,
They had no idea. They said it was maybe some algorithm thing, and like maybe some algorithm like.
They don't even understand their own algorithm.
No, they don't. And not to be critical of any individual person.
No. It's just how it is.
It's just complicated, and maybe not even fully disclosed to them. But seeing that, like, that hurts a little bit, and you have to say for yourself, like, wow, like just overnight, just like that, like my reach has been cut like that, but then you have to kind of after a while you have to say, all right, it doesn't matter. Like I'm not doing it for reviews. I'm not doing it for subscribers. I'm doing it for to get stuff out there. And if it's not reaching quite as many people, it doesn't negate the people that I am reaching. If that video isn't as successful. Well, like if only 3,000 people watch that video instead of 13,000 people, like those 13,000 people, they're still getting something out of that. Like it's still getting the likes, still getting the comments, still getting the engagement. And so it's okay if it doesn't perform as well.
Oh man.
But you have to get over. There is that initial like feeling really bummed and feeling like you've somehow failed to live up to your own expectations. That's like there's definitely that element that you have to get past, and it takes time to do that.
That's really what it is, man, because I've been struggling with this myself because see, and this again, I can't have this conversation with a lot of people. That's why I'm really happy you're here. This is therapy for me. The last few episodes have all been therapy for me. So struggling with creator burnout, and this is a dumb term, but it's basically
no, but it's real.
It's a real thing.
Yeah.
So I've been doing this since 2010. You've been doing this since 2011. We put our blood, sweat, and tears into it. It is now part of our identity, in terms of like this is a piece of who I am. I am this. And I told my kids the other day in the pits of despair, I was like, I'm done being ZDogg. I'm done. Like, this is it. I'm done. I'm driving them to school. They're like, Daddy, are you okay? I'm like, I'm done. And they were like, what do you mean? This is who you are. My kids say this to me. And I'm like, Jesus, like it's just so wrapped in my identity.
Let me just say that's great because my kids think my YouTube videos suck. So it's wonderful. Like you've already succeeded. That's already a huge victory. My son's always like, Dad, your videos are so boring. Like,
well, because your thumbnail, I'm looking at this. Okay, the diversity of sex, gender, and sexual orientation. That's the one that got you all the hate. Yeah. And your thumbnail, I wish I could blow it up. It's you got to see this. You got to see this. So this is the thumbnail. It's very hard to tell. But it's basically Eric standing next to a word that says sex. And he's just like, huh? Like that thumbnail is not going to get you egregious clicks for people who are interested in sex.
Yeah.
The thumbnail that would have worked would have been like some cleavage with you going, and it was like sex diversity, and that would have then the kids would have been like, Dad, your videos are cool.
Yeah, and then the dean of Stanford would be like,
and then
Eric,
the promotion is canceled. Exactly. So again, what you're doing is the perfect thing for that. But so it's interesting. So what you said about the reach dropping. So this happened to me this year too.
Yeah.
And it happened suddenly about the same time, mostly on Facebook, because Facebook's our major platform.
Yeah.
YouTube is kind of like, it's important to us, but it's more like the really smart, kind of thoughtful people tend to hang out on YouTube, and it's 50-50 men, female. And on Facebook, it's kind of like, hey man, I'm just like blowing off steam and I want to see ZDoggMD do something crazy. And there's also smart, thoughtful people. So it's a mix of stuff, right? But so I saw the reach drop off. Our number of followers started to drop off. Our number of subscribers started to drop off. A number of supporters started to level off. And these are the paying subscribers who, by the way, have saved my life. Like they are, meaning there's such a wonderful group of people that are willing to pay like $4.99 a month on Facebook. I want to talk to you about this too on the show.
Yeah, I would love to hear about your business model.
Yes, because I want others to take it. I want others to feel like empowered to do this and feel like they're getting compensated, right? Because it's a huge amount of work. And so these guys are a wonderful tribe of, like 6,300 odd people, and they care about even just sitting and chatting. They're super fans. They love one Sikh, like and so it's a wonderful, beautiful space where we can be open, and there's no anti-vaxxers and no trolls. And if you troll, you end up getting banned, and I lose your money, and I don't care. And there's a discussion group, and that's been great. But watching the sort of numbers decline, and then asking Facebook, asking YouTube, and having them say, we have no idea. The algorithm is the algorithm. Maybe Zuckerberg's promoting groups now instead, which he is. He's not in the news feed anymore. It hurts because again, this is your identity. Now, in a perfect world, Eric, it shouldn't hurt. We should exactly focus on the things that you said. And so the other days when I did those videos, and I'm like, I'm really feeling burned out, I got all these messages from people that made me feel like, oh my gosh, like we're connecting with people in a way that I never even understood, because you don't feel it when you're making a video. You're standing there, you're reading a script, I'm like expositing, and then you just put it out in the ethernet. You don't feel that even an individual is having this experience, that you've set them up to this connection. And when they tell you, then it becomes real. It becomes a one-on-one empathic event. And that has gotten me woken up again. I'm like, it's like you said, even if it's like 100 people who watch and are super engaged, man, what a beautiful gift to be able to do that as a creator. So that's a way to kind of ameliorate the burnout, is finding the purpose in it. Instead of focusing on numbers, YouTube changes its thing now. You can't look at the specific number of subscribers you have. It rounds it to some number because that's their way of dealing with creator burnout. It's a real problem because people are just looking at the analytics. wait, why did I lose 5 subscribers just now? What did I do?
Yeah.
It's me. They don't love me.
They're trying to, people, there's too much temptation to try to micro dissect every single little tiny little insignificant trend in your analytics.
It's true.
And you have to step back and be like the way I deal with that is like, I'm not going to look every day. Like I'll look once every week or two, glance at it. If nothing seems catastrophically off, then I put it aside.
What a disciplined approach, man. Which I would expect no less from you, because you strike me as
it's a lack of time.
Yeah, see, that's good. That's good. The problem is, part of my problem is, since I've pulled back from full-time clinical practice, I have the time to spin my wheels. You know, and it's funny, I don't have time for.
Well, you have to have one of your assistants, you know, spin the wheels for you.
I could,
and then like type a little summary report with like candy coated a little bit.
Victoria in the back could just basically look at analytics, and she does, and she gives me these reports and stuff, and I'm like, okay, I don't want to hear this anymore, because it's too much. And the truth is, like, you know, I get up at like 4 a.m. I go to bed at like, you know, whatever, 9, 10. I go to bed relatively early, but that whole time I'm thinking about what I do. I'm working on stuff. I'm answering emails. I'm answering fan emails. I'm looking at Twitter. I'm looking at Instagram. I'm thinking about what the next content is. I'm wondering about what talk I'm doing tomorrow. I'm thinking about a sponsored show, thinking about my subscribers. I'm doing all of this. And it's too much, dude, because you never are off. I go on vacation and I'm thinking about it. You know? Now, so I think what you're doing, I think it's very hard, but what I like is you've managed to sort of integrate it into your clinical activities. And so the only trick is, like, I really think you should get paid for doing this, because you're providing a service. And so
who's going to pay? Who's going to pay me?
It used to be, that was the question I asked, who's going to pay?
Yeah.
And the thing is, what I have started to realize is, and this, YouTube is doing this, Facebook is doing this. So there are membership models now where people can sign up to be subscribers of yours. And that means many things. It could mean they get exclusive content. It could mean they get CE credits for watching your stuff. And your stuff is perfect for continuing education credit.
Yeah.
So I'll talk to you later about how you might want to do that, because then you could actually monetize it. And what that means is then you buy more equipment and you make the production a little better, and maybe you get an assistant, because I think, Eric, you work too hard. Like, I really do.
You and my wife agree on something.
So one of the greatest things that happened is I suddenly had a team. I went from doing what you did, which was up until 2015. Every video I made was basically me. Yeah. And then and editing and sitting there and hours, 30 hours of video, whatever it is for music videos, much more than that actually. Yeah. Like 100 hours of video. And now Tom, Logan, Victoria, they help me do the stuff that I'm actually not that good at, and they do it better, and then I'm free to do the content, but I'm also free to spin my wheels looking at analytics and stuff that's not productive.
Well, you know what, something, you know, I remember, you know, because I followed you for a long time online, and I remember it was the ain't no way to die.
Yeah.
Like I don't know what, like I have no idea which videos came immediately before that, but something like that video, like seeing that, I was like, whoa, like, when did Zubin like hire like this incredible production team to put that thing out? Because like I was like, that was like legit, like well produced, like looked like it came from an actual studio.
So do you know the story? The story with that, I'd been wanting to make that video for a long time because I wanted to talk about end of life. Which, by the way, you did a beautiful job talking about your father, talking about end of life. You've done some videos where you've really transcended into the philosophical. And again, my fatherly advice, Eric, I'm like a couple years older than you. I've been doing it for 1 year longer. My fatherly advice is, I think if you do some unscripted stuff where you just speak from your gut about things that you care about philosophically in medicine, like people really want that. They really do, because they want to hear from someone who's experienced, who's done this, who clearly is caring, is clearly smart. But Ain't the Way to Die was one where I was like, this is a mission for me. I want this to have an impact. And so I recorded the song with a friend, Devin Moore, who ultimately ended up doing a lot of our production. I met him in Vegas. He has a band and all that. And he could actually make my voice sound good. Like, he was like, you need to get vocal lessons. He's like, you need to actually record in at least a makeshift studio. You need to do these things, and I'll mix it for you. And he made it, and then he sang the choruses on that. Just gonna stand stand there and watch me burn. He did that, and he made it sound so beautiful. And then I did the rap, and I was like, this song needs a proper production. And it turns out this group was doing a documentary at the time on the sort of Mavericks, and they were like, ZDogg has a clinic in Vegas, let's do him. And I said, oh, I have this song that I'm making a video for. Maybe you can come watch me try to figure out how to do the video with my handy cam or whatever. And they're like, we'll do you one better. We'll make the video.
What?
We will shoot the video.
No, you're not going to tell me they didn't charge you for that.
So they charged me a little bit, not much, because the documentary was covering the rest of it.
Yeah, wow.
And so we went out, and I've never worked with a team, and that opened my eyes for the first time that production. Remember I was saying we're all icons?
Yeah.
Well, the icons matter when people are looking at something like YouTube it's you looking at icons. So how it looks matters. The production matters.
Yeah.
So if we could give medicine the level of polish and production that Hollywood has, oh man, we could actually give us on the front lines a kind of a feeling of elevation. Like, oh my gosh, we're worthy of this. And now let's have this conversation about end of life. So that was the first time. And then Tom and Logan came on board, and then I was open to the idea of outsourcing this, because the creative control is a tough one, right? Like, it's hard to let go of.
Absolutely.
Like, if I show up and I'm like, Eric, I'll do your video for you, you'll be like, you screwed this up, man. Even if it's better, it doesn't matter, because my team was doing better videos than me, but I was like, nah, this sucks, this is garbage.
Because it doesn't feel like it's yours.
It doesn't feel like it's yours. Yeah. So it has to be integrated with who you are. You have to have some hand in the editing, and I always do. I micromanage everything, but at the same time, how Logan lights a scene, I can't think about I can't even come close to his eye and how he does that. Or Tom's thinking of like, no, this is what's going to have the emotional impact. Like, he can see it, I can't see it. Yeah. So it's really, that team is very important.
How did you recruit them?
So recruited them. They came to me, cold emailed me. Which, by the way, I hate it when people cold email me, right? Because I get thousands of emails, and it was weird because they emailed my assistant at the time, Melat, who was at Turntable Health, and was like, "Hey, we're a Vegas-based production studio. We saw Turntable Health got like top 10 startups in Vegas. We're like a top 10 startup in Vegas too in the same article." And Logan just reached out as a biz dev thing. He's like, maybe they would need videos done. And I told Mel, I was like, I'm not working with a film production team. Like, they're all just annoying. They cost a lot of money. I don't have how do I monetize this? It was the same thing. Yeah. I don't monetize this.
It's going to cost too much money.
It's going to cost too much money. And so I met with Tom just to be nice to Mel, because she's like, there's something about these guys, because she had the intuition, right? You got to trust your team sometimes. And then I sat with him, and we had like a 3-hour discussion about the nature of consciousness and the kind of things I'm interested in. And he was too. And I'm like, all right, let's just do this readmission video because it's dumb and no one's going to like it. And it ended up being our most popular video of all time. And I think it's partially because those guys made an amazing music video out of a dorky concept of like CHF readmissions, So my fatherly advice is, you have this amazing platform. There are ways to monetize it. So I mean, you can do talks, you can have subscriptions, you have ads. There are other things you can do, but I think really between that, then you could maybe get an assistant or someone to help you with the stuff, and then you could really grow it, because I think what you're doing is so important, and it's very hard to scale an individual.
No, it is. I mean, if I could, if I had the bandwidth to do 2 or 3 times as many videos, or have just a regular publishing schedule, like, I would totally jump on that. No bandwidth. So
I'm going to tell you something that you're not going to like to hear, and you're not going to believe, but you could actually make a living to where you could actually cut back your clinical stuff if you if you really focused on this. I really think so. And again, I say that partially to encourage others that this is a thing. We need it in the world. It's super important. We have the Dr. Mikes who are great. We have the ZDoggMDs who God knows what they are, but we need more of the Eric Strongs that are out there teaching, in a way that actually helps people to learn, with the credibility of having the education and the training and the academic credentials that you have. That's very important. Again, it's not necessary, but it's definitely a nice thing.
Well, I appreciate that.
Yeah. So any other thoughts before I'll give you an off-camera tour of what we do and show you the equipment?
No, I don't think so.
Man.
Any other questions you had?
No, this is just therapy for me. I really wanted to shine a light on what you're doing and ask you the questions. And I'm fascinated by your process because it's so different than mine. Yeah. And I think others should really be inspired to try this out.
Well, what I think is great, though, is that like YouTube has a space for having 2 physicians who make videos have completely different processes, different sort of techniques, different setups, different goals in mind. And there's like, I mean, if someone out there, if there's other physicians that have been like tempted to like put something out there on YouTube or Twitter or Facebook, whatever, like you don't have to follow our model.
Yeah.
Right. Like you have an idea that's totally different. Like, dude, try it out. Run with it. If it doesn't work, it's okay. Like, it's not the end of the world.
I'm 1,000% with you. Just don't make those annoying thumbnails. Who's your favorite medical YouTuber?
Oh, wow. There are a lot of great ones out there.
There's really great ones. Yeah.
I hate to give a shout out just to one because I don't want like other buddies of mine to feel like they've been shortchanged.
Yeah, I don't feel like you have to.
But I will.
Okay, good.
So Midlife Crisis. I don't know if you know the guy.
I was gonna say the same thing.
Rohan Francis. He's a cardiologist in the UK. He's come out of nowhere just in like the last like 18 months or so, putting out like really like videos that are they're like the perfect blend of information, humor, and the ability to target. Like if you ask him who his target audience is, like I would guess he would tell you everybody.
Yeah.
Like you could be like the most esteemed senior physician, or you could be like someone that doesn't know squat about medicine. You could watch one of his videos and feel like that was a satisfying use of your time.
Rohan Midlife Crisis, and I got it turned on to him because he called me out in an episode about like social media doctors. And he said some really nice things that were very frank. He was like, and he's on Facebook, which I didn't even know that was still a thing.
Yeah.
And I'm like, neither did I. I started watching his stuff and I was like, I felt that you feel exactly like you do. It's like game recognized game. Like this guy came out of nowhere. Yeah. He's diligent, you can tell, because he puts his videos together with a lot of thought. He's not just freeballing it, right? Like I am. He's like going in and he's putting a lot of thought into it. And I'm really happy that you agree. It's funny that we didn't talk about this at all, but we both cite the same guy. I hope he does really well. I hope he grows. And
he seems like he's really taken off. So.
Yeah. And you know what's weird is there's a competitive aspect to what we do, but there's also like this joy when you see somebody doing it right, and you're like, dude, that's awesome. Yeah. Like that's really cool. What can I steal from that guy that I can bring to my audience? Because again, like you said, YouTube has space for all of it.
Yeah,
all of it.
Yeah, it's funny because you talk about the competitive aspect. One thing some people will say, like, who do you recommend? Like, who do you really like on YouTube? And I have to be careful because I can't recommend someone that is like too close to my niche.
Yeah,
right. Like this guy makes videos that are like really similar to mine. He's awesome. I'm going to recommend this. Like,
I can't do it.
I can't. It's the same. We're occupying the same niche. I can't do that.
That's really interesting.
I still really like their videos. I still do a great job.
I used to feel like maybe when I first found Dr. Mike, I'm like, who is this mother flipper? I'm going to destroy him. I looked at his videos and I'm like, okay, we're going to do a real doctor watches a dumb doctor talking about stupid stuff.
Yeah.
That was the plan. And then I watched his videos and it's like, this kid's okay.
Yeah, no, I feel the same way about him. So it's like, oh, Insta Doctor. Like, Insta Doctor that has his billboards up.
Exactly.
Like that's ridiculous.
He's gonna suck.
He's gonna be like Dr. Oz, but like without worse. Any experience.
Exactly,
like,
without the cardiothoracic surgery professorship. Yeah. Right, exactly.
And then you watch his stuff, and you're like, oh, like, I can't disagree with anything he's saying.
Disagree.
Like, this,
I can't disagree.
Yeah.
And then I met him, and I'm like, good, sincere.
Yeah, he seems like a legit dude.
Literally a kid.
Yeah.
Good, sincere kid. Like, really wonderful person. And so... But I wanted to hate him. And again, it's because this is a little bit where we're so kind of competitive as a species, the physicians in general. But again, to be in a space with other creators, there's a joy, right? Because you're just like, well, so how do you do this? Well, that one video you did, how did you pull that off without pissing off? It's really fascinating. Yeah. Again, so this has turned into a kind of an inside the actor studio. like this is how the YouTube creator healthcare professionals do things. And the nurse side is really interesting too. So there's like Nurse Blake, who's kind of blown up and is just really witty, funny nurse who just makes people laugh with like, oh, it's funny because it's true kind of thing. Yeah. And you know how he monetizes it? He does like cruises and stuff for like a bunch of nurses come on cruises.
I had no idea.
See, I would stab my eyes out if I had to do like a ZDogg cruise. Like, could you imagine the Love Boat? Hey, ZDoggMD. I would die. But again,
her wheels right now in her head are turning like cruise.
ZDogg cruise.
Maybe we should run with that.
Yeah, Victoria's
thinking about it.
Yeah, she's already like, let me run the numbers on this and see if we can get a Norwegian Cruise Lines filled with supporters. You know what we are thinking about doing though that's interesting is a Netflix concert special. So yeah, I know it sounds crazy. The show that I do, the 1 hour, 1.5 hour show that I've been doing for several years and evolving, that now I did at Stanford, and I think it's ready to, like, you put it on a stage with a bunch of audience and shoot it and get it out to the world and go, this is what medicine can be. Yeah. This is what it has been. This is why we're hurting. Yeah. This is what it can be. Now it's on you. Have music and have the thing, and just put it out and see if Netflix wants it. And then I'm done with that talk forever. Yeah. And it's out in the world. And so that's another thing I've been, like, mulling about. Yeah. But yeah.
Do you have contact people, or?
Not yet.
Okay.
I'm going to try to search for some.
Do you know Monica Bergava?
I do.
You know, she was not her video, but Netflix.
Extremis.
Yeah. She was featured in Extremis.
Wait a minute. So why am I such an idiot? I interviewed the producer of Extremis on my show, Shoshana Ungerleider. I'm like, do you know anybody? No, I don't know anybody. Wait, what? I'll reach out to Shoshana. She has all the contacts. Yeah. Thank you.
That'd be great.
I completely forgot. See, again, like, I don't get to talk to people about what I do because nobody does what I do, but you do. So this is a joy for me. Eric Strong, thanks a million, dude.
Yeah, so, no, it was great. It was really fun.
Let me just shout out to people. Okay, it's Strong Medicine on YouTube. Your Twitter handle is at Dr. Eric Strong, EricStrong, right? Yep. And
my Twitter feed's a little bit more controversial than my YouTube channel is.
Yes, I know. I know. Oh, you know what? I wanted to thank you because you privately supported me on something that was a controversy on Twitter.
Yeah, I remember that.
Yeah. And I was like, this guy gets it. Yeah, you understand. Because the mob on Twitter can be...
It can be rough.
It can be rough.
Much rougher than YouTube.
Much rougher than YouTube. And the thing is, when the mob is your own people. Yeah. So in other words, they're like maybe the center left or the left. The left are not my people. The center left are my people. The left has gone insane. And again, I won't get into that. But they've become basically word Nazis. You cannot speak. Free speech is not a thing anymore. Yeah. So, and to me, free speech is the one sacred thing. Like, you don't mess with that. So... even anti-vaxxers, they should be free to be idiots. That's fine. You can do that, but you're not free to avoid the consequences of it. So thank you for supporting me on that. But what was the point? Oh yeah, so your Twitter feed is a little more controversial. Yeah. And then do you do Instagram and all
that? No Instagram. No Facebook.
Got it. Okay.
Don't trust Facebook.
You know what? I don't either, and it's my major platform.
Sorry, I didn't mean to like diss any of his supporters.
No, actually, I have a lot of my fans on YouTube don't do Facebook, and so it's good to be on both. Yeah.
Yeah. I'm not against people on the platform. I don't trust the platform itself.
Yeah. You know what? Can't put all your eggs in any platform. That's another piece of wisdom, because at any point, the platform goes, or you're canceled. You say something where YouTube decides your hate speech. Yeah. Because, you did a thing about the diversity of sex, gender, and sexual orientation academically, and somehow they tag that as hate speech.
And that's happened. YouTubers that talk about sexual identity, YouTubers that talk about history. Yeah. They channels are getting flagged for statements that are not controversial. Yeah. But YouTube flags them anyway. They get demonetized. They don't get kicked off the platform. They get demonetized. Yeah. Which for people, if you're a professional YouTuber, like,
you're kicked off. That's basically being kicked off. This is their life. Yeah. That's why you need diversity of income too. That's the other piece of wisdom.
Yeah. Or being married to a physician.
As both of us are. Both of us are. Is your wife Asian?
She is.
So is mine. So we diversified race, we diversified specialty, we diversified, it's perfect. The only thing is that all our eggs are in the medical basket. Yeah, that's true. We didn't do that right. Yeah. But it's okay. We should have married.
If the American healthcare system totally collapses,
we're doomed. We're but you know what? There's always other stuff. Then we make the videos that are like, sex, and make the thumbnail, and that's how we still get paid. Oh, man. Eric Strong, dude, I could talk to you all day, and we're going to after the show. I'm going to get Victoria. Victoria's got to go pick up my kids. So we got to end, but it's been a joy. You guys check out Eric's stuff, subscribe to his channel, subscribe to my channel, do whatever you want. I'm no longer gamifying this. I'm no longer obsessed with analytics. I'm just obsessed with connection, and I'm really glad we got to connect today.
Thank you for having me.
It's my pleasure, and we out, Z-Pack. Peace.